I'm very happy to have with us today Cathrine Trulsvik, and she's going to talk about how midwifery models of care can change the motherhood. She's a midwife and nurse here in Norway with extensive experience in prenatal, birthing, and postnatal care. After working in hospitals, she transitioned to providing home birth service with a fellow midwife. But in 2017, due to economic challenges and a ban from home birth, they ended their practice. Since then, Cathrine has focused on advocating for informed birth choices, organizing the Birth Festival in Norway annually. In 2021, she founded Birthrights Norge, a voluntary organization supporting women's rights during childbirth and assisting midwives facing complaints. Again, here we have a hot topic. Cathrine, thank you so much for being with us today. It's so important to have you and to talk about these issues. Looking forward to hear you.
Hello. I am really, really happy to be here, and I was able to look at the most of the speeches yesterday and of course today, and I can see that we are facing the same, challenges and also opportunities throughout the world. And it's so good to be, gathering together and to feel this support. And I, I was listening now to Anita. Her focus is, the same as mine. And I just have to say one thing about that, because one thing I've been reflecting upon is how it's difficult, even impossible to go into war and fight when you are in the labor room. So every fight you have to do must be before. Hopefully we can change it so that the fight will be in society and not when you are pregnant even. And then you can have your support with doulas and midwives, and they will be your advocate, and you can, birth in your own way and be sure that you will be taken good care of. So I have to say thank you, Susanna, for inviting me. And I have a presentation, so I share it with you. So maybe you can share the screen. I want to talk about how midwifery models of care actually can change the motherhood. And So now I was thinking, okay. My problem now is I cannot, I cannot take it to the next. I checked this just there. Okay, so you're with me?
Yes.
Yeah.
You just changed slides.
Yeah. Okay. So this is me. I'm attending a home birth for a few years ago. And I would just tell you a little bit about me. You did that, Susanna, but I became a midwife in 2000. And then I walked out of the system in 2011 to become an independent midwife. Then I had home birth for 5 years, and then I founded the Birth Festival in Drammen in 2018, and the Birthrights Norge, an organization, in 2021. And also I was more and more confused, and I needed to know more about the law. So I educated myself in healthcare rights, ending in 2024. So what is caseload midwifery care? This is the one model of care that I'm thinking we can convert to, and that a lot of things we are struggling with now can be better. A research-based model of care for women and midwives. So it's both for the families, and then it's also for the midwives to continue to be to love their work and to be compassionate and to be personal and to make a relational care. So caseload midwifery care is a model of care that implements time continuity from the same midwife and an individual and personal approach. This leads to truly safe care, as in emotional safety, trustful relationship, and healthier women and pregnancies. We have Professor Jane Sandel from London, who has been studying this and made several research, both in 2016 and 2024. This truly safe care opens up for the woman to connect and bond with her baby in the womb. The trust she feels, both to the baby, herself, and to the midwife, will optimize her health in pregnancy, in the birthing process, and further optimize her feeling of coping during birth and after. Her energy to connect with herself and her baby will rise, and her health will more likely stay strong. So it's a good thing for society that we protect women and families during pregnancy, birth, and the time after. How does caseload midwifery care work in practice? So midwives organize themselves in midwifery teams, and they invite women to get their follow-ups and support within this small group of midwives. The follow-up will continue throughout the pregnancy, during birth, and a few weeks after the baby is born. I know this is maybe known for many, but maybe not for all. So that's why I want to tell you. It can be slightly different from place to place, but usually women will come for their follow-up at the midwife's office, and then the birth starts. The woman will have the possibility to get the midwife home. When the midwife arrives in her home, they will decide together when, or if actually, they will go to the hospital. The midwife will stay with her during labor and support her until the baby is born and the time after. She can then decide if she wants to go home or to stay for a while in hospital care if she actually went to hospital. And then when she comes home, her midwife will be there for her, and they will make plans together. So why does it matter? And how can it change the motherhood? Because actually it makes relational care and emotional safety possible. I see that if we don't do it like this, it is really difficult to make a relational care and emotional safety for both parents and also for the midwife. So there is no truly safety without emotional safety. That's a statement. We go on and on about how safe it is to have a baby or to birth a baby in Norway and other countries, I believe. And we are at the top of safety, medical safety in Norway, but it's being too much because, or maybe not too much, but we are not allowing women to choose. What Anita talked about, the right women have to make choices from information that are, truly true information from research and from experience, and then combine this with woman's experience and wishes, and what does she have to get, the emotional safety? What does she need to feel emotional safe? This is so important, and when we can start by knowing the woman early in pregnancy, it will be more easy, actually. So I'm just looking at the World Health Organization and what are their recommendations. And almost every country are following the World Health Organization. So why do we not take this into consideration? WHO says midwifery is defined as skilled, knowledgeable, and compassionate care for childbearing women, newborn infants and families across the continuum from pre-pregnancy, pregnancy, birth, postpartum, and the early weeks of life. It says it all here, actually. All women and newborns have a right to a quality of care that enables a positive childbirth experience that includes respect and dignity, a companion of choice, clear communication by maternity staff, pain relief strategies, mobility in labor, as Anita talked about, and birth position of choice. Midwives are essential to the provision of quality of care in all settings globally. We need to, act upon that. So this is me again, preparing for home birth with I think she was expecting her first child, actually. And then I've been thinking about what is emotional safety. What is emotional safety? Well, first of all, it is highly individual, which means the support has to be relational and personalized. And in order to do that, the trust is essential and the time is essential. Build trust takes time. This is trust. This is time. This is love. This is home birth. So, my story. I don't know when I started to think about how maternity care should be, but I think my story can give you a little hint. As long as I can remember, I wanted to be a midwife. Actually, I was 5 years old when I claimed I wanted to be a midwife. I don't know why. No one in the family was a midwife. My mother didn't know I knew what a midwife was. Anyway, I finished my nursing education in 1992, and I started my midwife education in 1999. I became a mother to Martin just before finishing my midwife education. In retrospective, I remember how I felt disconnected to my body in the beginning of pregnancy. I didn't believe it. I just felt fat, and I could really not believe I had a baby inside of me. I actually, I needed a ultrasound early just to understand, even though I didn't want the ultrasound, but I really couldn't understand. After a while, when I felt him move, I started to believe he was there, and I was starting to bond with him. I did not connect the pregnancy and the birth with having a baby. For me, this was 3 separate events. When I went home from hospital, actually, I felt I took a baby home with me from work. It was really special, but I loved him and I took the cutest one. So it took a while before I got to know him. This was not something I worried about or felt traumatized about in any way. But as the years passed by, I have been reflecting around why I felt like this. Even though I had the best antenatal care with my own known midwife throughout the pregnancy, the focus for me was the baby and the birth. I did not have the mental capacity to truly see the connection between pregnancy and my growth as a woman. Intellectually, I knew, but for me to integrate it was not possible at the time. I think, actually, somehow it was what I expected as an educated nurse and midwife. Maybe I'd been thinking different if I didn't have this education. It was standing based on my education. This leads me to how our education forms us and how important it is to change it for the future. And for the present, we need to reflect upon it and learn from women and their experiences and needs. Only then can it change. My relationship with my children is good and has been good, and I don't feel I was harmed in any way. But my own feelings and experience made me think about what we as midwives can do different in our care for women. I also want to say that about this speech about the adolescents, it's so important. I remember when my daughter was 12, she talked to a girl at her school, also 12, and she was talking about me being a midwife, and her friend said, to having a baby is worse than burning in hell. That's quite strong. So talking to children and adolescents and to find out, to start this conversation early is really important. It was when I started working as a home birth midwife in 2011 that I began to understand what is important when it comes to bonding and the relationship with the baby in the womb. At that time, I learned actually from women how it started, how they felt from the early beginning of pregnancy and throughout the pregnancy. And they learned me so much. I learned so much from them. When we understand how pregnancy, birth, and parenting are closely connected, it makes it easier for us to bond with our baby. But it is maybe even more important when it comes to understand yourself as a woman, mother, and a lifelong caregiver for your children. When a baby is in the making, a mother is in the making as well. When a baby is born, a mother is born. Every time. So in 2011, I left the hospital to start working with home birth. My need to offer something else than fragmented care grew bigger and bigger as the years passed by. And after 11 years in traditional care, I needed a change. I worked 5 years with home birth in a continuity of carer model of care. It was really fulfilling. We were 2 midwives working together, and for the families, we really felt we gave them the best. So it ended in December 2016 for different reasons, what also Susanna mentioned. It was economic problems, and it also ended with me being banned from home birth. Since then, I have arranged the birth festival, Fødselsfestivalen in Drammen, close to Oslo actually, as a yearly event. And then I started this voluntary organization, Birthrights Norge, in 2021. Woman's health is closely connected to how she feels during her pregnancy and how she bonds with her baby in the womb. These are my reflections after so many years with women during pregnancy and birth. How she birthed her baby and how she experienced her birth is connected to how she felt during her pregnancy and the type of support she got. How she is trusted and respected and the knowledge she gains during pregnancy is vital for her growth as a mother, woman, and a human being. This is why we need to offer humanized, safe, and individual care to each and every woman from the early beginning of pregnancy. The most important change we need to do is to get it right is, I think, to change the model of care. That's the beginning. That's a really important beginning. We need to talk about how fragmented care is less care and more control. It is difficult for the healthcare to trust a person without knowing her. It results in the need of more control from the healthcare. And actually, we're talking a lot about how women are supposed to trust the healthcare, but I think we need to talk also about how the healthcare, the midwife, the doctor, needs to trust the woman. As a result of this mistrust and how it's more control, the woman often feels powerless and infantilized. And this is when the obstetric violence comes in, actually. When you combine all this with the midwife's fear and stress due to little resources, the need for procedures and more control to make the care effective and safe are rising. So trust comes with knowing each other. Getting to know each other takes time. We need to accept it, understand it, and act upon it. Worldwide, the models of care that offers continuity from the same midwives throughout pregnancy, birth, and postpartum are well known as the best for women and families. Why are we not doing it? My experience as a mother and a midwife tells me we need to change both the education and the models of care. My belief right now is that we can start with changing the model of care, and then the experience from this will change the education. So I have hope, actually. But we cannot stop fighting, and we cannot not stop having these discussions, these gatherings. We are a small world, and we have to stay together. Thank you. Love from me.
Thank you so much, Katrina. Thank you so much. What a wonderful presentation. Again, one of these topics to our panel is about social health of mother and baby, and this is what we are talking about. The rights affects not only the women, the baby, the father, the families, but the whole society. I think it's very important when you mentioned about the education and the model of care. I think there's many fronts where we need to fight to establish a change in the model, in the system that we are working on. So I think sometimes people come to us and with in different fields, because Prenatal Alliance is an alliance. So we congregate everybody that is working on the prenatal, but not only on the time of pregnancy, but also on the time of preconception, in the even and postpartum. Because when we are talking about education, we cannot just educate about pregnancy. We need to educate on how a soul comes to the world. And I think we should also work in many fronts. And doulas have their role in it, midwives have their role in it, obstetricians, medical physicians, society as a whole, prenatal educators, and I think that it's so important that you also have mentioned education in your talk. I am here in Norway, so I have to talk a little bit about this. I think Norway has a world responsibility on this, because I think the Nordic countries, which are often said that have a lot of good social system, good economic system, so they are up on the front of everything. They are not. A lot of times they are not. There are things that we also here in Norway we need to change, and you have reached on that topic, but also because other countries look up to Norway, right? And models of care and models of education, there is a responsibility there. If we have the fame, right, then we should also have the work done, not just be famous about it, but also show how things can change positively for mothers and babies. That's why I think it's so important that, for instance, Norway be the first country to recognize the World Pregnancy Day in this establishment, in the role of education, and in the role of changing the way that we see pregnancy and the health care. So I hope that organizations can blend in together and make this a reality, because there is a power here of being a small country. We can do a lot because it's a small country. And it's not that because it's a small, then it's not going to, no, because it is small, we can all even get even more together and connected and make this. And I think you put up a point really, really, really well stressed. It's not just about these gatherings. We do these gatherings, we talk, we go home, and we need to continue the work. It cannot be just the gatherings. We need to continue to do the work. And how we do the work, as Prenatal Alliance believes, is through cooperation. It's not an organization just leading, it's several organizations leading the work. That's how we can do, because we know that working in organizations sometimes is just 1, 2, or 3 people that are able to move and to do and have time, because we all are mothers, we all are in different times in our lives. So I'm so happy, really, really happy that you are here, that girls are here, and that we can blend this and make this a reality. Thank you so much for your talk. It brought again highlights, and it's blending beautifully with what Anita was talking about. How do you view? I just wanted to ask you this: how do you view the change that needs to be done in the system, specifically in Norway?
Can you explain this question?
Yeah. What do you think is the challenge here?
Okay, yeah.
Be changing.
The challenge is that we are standing in each are, with the foot, the doctors and the leaders are saying we cannot change what we have because there is too little midwives. Now they are, they have some reasons for not changing it. It's too few midwives now, and they're trying to educate more midwives. This is a known challenge throughout the world. We know that a lot of midwives are not working in the system because they cannot handle it. So if they could change the system, I think a lot of midwives would, just turn up and start working again. So they are blaming the lack of midwives, and then they are blaming the women, actually, because they are saying that the women needs more what do you say, overwalking. What's that? They need to be monitored more, so they cannot be at home. We have a huge discussion now about home birth or hospital birth and about monitoring or not. And we have one hospital starting the caseload midwifery care in a small, actually, as you said, it is easier to change when you are not so big. So this medium hospital in Drammen, they have been starting caseload midwifery care, and hopefully we will see other hospitals start it as well. And then from there we can, prove to the ones who are critics around this that we will handle it. It will not be more expensive, and it will reduce the complications, and it will make midwives more happy, and of course the main goal to make families more content and more happy and ready to go out to be in the world again.